So thank you all for being here. And again, I'm sorry we started a little bit late. We have a great panel. Oh, Jim, you are in the panel. Sorry. Come on up. So we have a great panel, Dr. Sands, Dr. Bhattacharya, Dr. George and Dr. Cohen from GI, Dr. Kaitov from colorectal surgery, and a special guest from advanced endoscopy, Dr. Jasauza, because our second case involves some questions about a potential advanced procedure. So I'm going to start with our first case. This is about medical management in UC, and if the person who submitted this would like to chime in at any point, please feel free. So 47-year-old gentleman, history of hypertension and obesity, CKD, iron deficiency anemia, and pan-UC, multiple medication therapies, now needs a change in therapy because he's flaring. So 2015, he develops fecal urgency, loose stools, small volume bleeding. 2021, he goes into the NYPED. He's short of breath, has an elevated CRP, his calpro is greater than 1,000. He's also uncontrolled hypertension. He gets a colonoscopy in March 2021 that shows pancolitis. Path is consistent with IBD. So he's initially started on combination therapy with adalimumab and 6-MP. He's clinically improved at week 12. Sorry, I just can't see. But he does have a low drug level with low level antibodies, and so he's escalated to 80 every other week. 8 weeks later, he has ongoing low adalimumab level, and actually at this point, intermediate level antibodies with an optimized 6-TGN level. And in September, he's actually hospitalized with a lower extremity DVT and a gigantic PE. He also has a new CKD. He's discharged on anticoagulation. He has a negative hypercoagulability workup. October of that year, he has worsening symptoms. He's positive for C. diff. He's treated. He gets a little bit better. But he has a repeat calpro that's 3,600. And again, his adalimumab level is low with intermediate antibodies. So he's escalated from 80 every other week to 40 weekly. He doesn't follow up for the next 11 months. And then he returns in 2022 and his colon again shows pan-UC. He started on vedolizumab. By week 12, he's clinically improved, and his subsequent calprotectin a year later is 324, so markedly improved, then down to 299 at the end of 2023. He has a colonoscopy with improvement, but not perfect, in July 2023. This is on vedolizumab. You can see that he still has probably Mayo 2 pancolitis. So he switched to ustekinumab, and because he was so sick, he actually started on Q4 just from the beginning. Post-induction, he has a really low fecal calprotectin, but subsequently it goes up to, I believe, 1,500. So then we're up to this year, January. He says he's doing better for the preceding year, but his colonoscopy, this should say at 24 weeks, not 52 weeks, shows again ongoing pancolitis. So he switched to mirikizumab from ustekinumab. And again, somewhat better clinically, but still with a really high calprotectin, and at week 16, really high calprotectin. And again, I'm sorry, this colonoscopy is a shorter interval. He still has pretty significant pancolitis. So just to recap for everybody, he tried adalimumab in combination with 6-MP. 6-MP was optimized. He never really got a good adalimumab level and developed intermediate level antibodies. He was then trialed on vedolizumab with inadequate response, ustekinumab at every 4 weeks with inadequate response, and at some point a level was checked. The level was low, no antibodies, so then he was reinduced, didn't really get better. Then on mirikizumab, still really sick. So things that haven't been tried would be infliximab as well as upadacitinib, remembering that he had and KIRKUD, remembering that he had this massive PE that was unprovoked.
The pulmonary hypertension will offset.
Question one, I'm sorry, as well as S1Ps. So question one for the panel is, what would be your next therapeutic choice? Would you try upadacitinib given that he's already on anticoagulation? Are you concerned about his PE history, or are you like, well, he's on a Pixaban anyway? Would you try an S1P? Would you try a different IL-23? Are you at a point where, would you try infliximab even though he never really got to where he needed to be with adalimumab, with sort of proactive therapeutic drug monitoring? Or when do you consider surgery? So Dr. Sands, you're nodding. I'm going to hand it to you.
Yeah, I don't see why you wouldn't try infliximab. He hasn't had an adequate trial of an anti-TNF because he never achieved a level. Whether you can get to an adequate level is another question, because it seems to me that he has probably very high clearance. So it could be tough, and I'd start at high dosing, and I would certainly do proactive monitoring in this case to try to get him to where he needs to be.
And in this case, proactive monitoring, you would check a level before infusion 3?
Yeah, I think
Aim
so.
for greater
right.
than 17?
Yeah.
Okay. Other thoughts?
Weight loss strategy.
Weight loss strategy. Can you expand?
Surgeon doesn't
I
want to
can.
operate on.
So you can operate on pretty much anyone to do subtotal colectomy. You know, we do it all the time on very sick patients, obese patients, thin patients. When it comes to that, we do it. The question is, what will be the next step? With BMI of 39 and active proctitis in a male patient, it equals most likely cuff left, with a not ideal restorative option.
Yeah.
Other option would be completion total proctocolectomy with permanent ileostomy. But the risk of perioperative and long-term postoperative complications with patients with high BMI is very significant. Stoma issues, retraction, parastomal hernia, etc., etc. So, while if you have time for this, if you initiate infliximab, definitely would consider some sort of weight loss strategy, either medical or like dietary, something.
Another theoretical reason is the contribution of obesity as being a risk for high clearance. What the mechanism of that is not clear, but it is clear that men, especially overweight men, have higher rates of clearance and lower likelihood of responding to anti-TNF.
And the same goes for anti-integrins also. Vedolizumab had shown low albumin, high BMI, increased CRP are all factors for increased clearance. There's a pharmacokinetic data done from Takeda itself where 6,000 samples were studied, and it's the same thing.
So why don't you start combo infliximab plus GLP?
So I think that's a great idea. And actually, we are going to have Dr. Gold talking about GLP-1 use in
GLP plus
IBD.
6MP.
And does the person who contributed this case want to say what they did?
Yeah, I could restore it.
I'll make him laugh.
The weight loss is one of the things that we tried many years ago when we noticed that he had issues responding and had high clearance. I was not very successful with the weight loss, let me just tell you. I don't know, there's a sex rate that you may have, but it's hard in patients to do it. We've tried GLPs and he doesn't really tolerate them. However, just to give you a full clinical picture, he does have renal failure at the age of
It's failure now?
40s. And he's now had about 11 years of ongoing inflammation. So I have not been able to really even consider surveillance of anything. And we did start about 8 to 10 weeks ago. We did start infliximab. So we loaded him.
They started
We loaded him
infliximab.
at high.
Sorry, I was just telling the crowd, spoiler alert, they did start infliximab.
Yeah, we did start. Yeah, I'm going to mention it because Bruce mentioned it, and I already have a few data points from the progression after he was loaded. So that's going to lead us to the second question, right? But anyways, he was started.
Guess it didn't work.
I did some close monitoring. His Calpro has gone in about 8 weeks from 3,000 to 800. The patient's clinical symptoms have improved dramatically. He just goes he says 3 or 4 times. The urgency is gone, but he still has Bristol 5 and 6, not quite where we wanted. He is on a combination therapy. And I'm following him very closely because of the renal failure. His white count has dropped a little bit, but he's still not neutropenic enough. And his CRP, interestingly, has actually gone up on this. So I have a mixed response again. I have somebody that has responded a little bit.
Does he have levels?
Labs are showing me different. I don't have levels yet, and I just changed them to, he's on 5Q, right? Because you wanted to start like that. But the question now is, we're getting to the point is we may fail again. And I'm going to try to go either to 10. And the major question here is that when do I think about Jack, considering his history of a massive PE? He's a young patient, so we don't want to cause any harm.
So,
Saurabh, did you want to say something?
No. I was just wondering what his ethnicity is and what are the risk factors for him having this multi-drug refractory. Do we have any understanding regarding that?
Do we have any understanding of his risk factors for multi-drug refractory UC, and what is his racial ethnic background?
what are the risk factors for drug refractory UC?
Well, well, so can we identify, maybe he has multiple family members, maybe he's super,
But
he
this is
got
not-
it when he was super young, maybe there are other things that we can try
So-
to understand.
Was he he wasn't diagnosed at a particularly young age because it was 2021.
Pancolitis,
Pancolitis.
Diagnosis.
Any family members, and what's his racial ethnic background?
He's Hispanic, and his phenotype is severe pancolitis. And as far as why he would persist, I'm not sure about the underlying immune mechanisms why he resists so much, but definitely he's obese. He's Hispanic, it's a little controversial if this works or not, but definitely no family history of this.
So, can I ask you
Any
something?
question?
I think amongst all the medications that have been tried, the only thing that I saw had any kind of effect was the Entyvio, right?
Yes, that led to a reduction in the inflammation.
I mean, absolutely, this person needs to discuss surgery with a surgeon right now. But maybe it might be worth considering stacking up the Entyvio on the infliximab. They have completely different mechanisms of action. It might give you some purchase if the person is completely going to refuse surgery. I mean, we have other IL-23s also available, but this seems like this is the kind of guy where we are losing a lot of time on, and we want to get ahead of the disease rather than the disease getting ahead of us, which it probably already has.
Jim,
too
did you
late.
want
I
to
think
say
one of the
something?
biggest risk factors, at least that I'm hearing in the story, is time. I think this has been going on
That's
for a while,
absolutely.
and his Humira, given his size and his clearance issues, starting with something like Humira, I don't think he will ever really get to a therapeutic level. It's not a weight-based sort of dosing with that drug. So I think the amount of time that he's sort of been spent, as you mentioned, Lincoln, good to see you, Lincoln, and he's been inflamed for 11 years, the momentum of that is really difficult to overcome.
But
I
you
also
can-
think we're
you can
using.
We started, we had issues with compliance at the beginning. This is back in the other options were not available yet. So as soon as they were available, things changed. But at the beginning, the Humira was chosen. It was one of the acceptable treatments back then. Remember when it was. And he had a little issue going into getting infusions.
Yeah. So
go ahead.
I fully agree with the point, but
Or not.
retrospectively,
Should switch with
maybe
Jean
we
Fred.
should have started this patient on ADA.
Yeah.
Because we are losing time, but this is
They want to
very
pull
well
the
explained.
Entyvio,
This is
just
what
two
we had at
infusions
that
also.
time. Regarding your question, there are some data showing that you can use JAK inhibitors in patients with past history of PE as long as they are on effective anticoagulation. I mean,
Okay.
there are some case series, there are data showing that, but it's still risky.
Dr.
This is-
Collenbell said there's some data,
Yeah,
some
it's
case
a-
studies demonstrating that you can use JAKs in patients with history of DVT or PE, but they need to be on therapeutic
Exactly.
anticoagulation. Dr.
Maybe
Livanos?
antidote.
Oh, I was just gonna mention his PE, possibly is due to his ongoing inflammation.
Right.
So,
Mhm.
Always have to balance
so
that
balancing
potential
that
risk.
part, of his ongoing inflammation is a risk factor in itself for PE.
Lu-
This guy having surgery is going to also be a big deal, and he's not going to have probably an acceptable quality of life with surgery. So I actually wouldn't be opposed to giving him UPA if infliximab doesn't work at good levels.
I think you can do whatever you want. I think, but I mean, but I think that the issue that's happened with him, which I think what it illustrates, is one, there's been a reliance on markers that aren't validated in that way, right? Calprotectin, it's nice if it moves a little bit, but outside of complete normalization, right, we don't really understand what that means. And his colon is burnt out, right? So his bowel movements haven't told you much for a long time. I mean, he's somebody that I wouldn't hesitate. I mean, a quick flex sig in your office or wherever it is, even unsedated, I think you need the right data in him. And I think that that's part of what's happened is it's just been, as you said, constant inflammation now for 11 years. And he's already shown you can't rely on his symptoms. So I think that as you trial each drug, these are drugs that work fast, right? Mucosal healing, especially in UC, happens quickly. I think the longer you leave him on these things, and that's why I think S1P is not an option, he's just building up more and more, morbidity. He now has a PE, he now has renal failure.
Yeah.
So, you know,
Without the history of PE, this would have been a slam dunk, right? Jack. I believe me, I would like to introduce him to Sergey. Sergey's a nice guy, but he has a BMI. I said 39, but he's 42.
He's changed since the beginning of this, since
Yeah,
we
but-
first started collecting slides for this IBD
But
brief.
we
now
don't
he's
have
a-
a level yet, but
No.
you could almost guarantee that the levels are going to be inadequate because of the CRP not dropping.
Yeah.
Remember that
Yeah.
CRP is
Yeah.
downstream from TNF. You know, there are other things that drive CRP as well. But if you don't see a drop in CRP, it's almost a guarantee that the levels aren't okay.
I want to give Dr. Rubin a chance
Or it's
quickly
not
because he's
working.
had his hand up. Dr. Rubin, did you want to say something?
You're
Sorry,
muted.
unmute. You got to unmute.
I wanted to ask whether the risk of thrombosis is so great in someone who's already therapeutically anticoagulated.
Right.
But you will need to
don't know.
to higher dose,
Higher dose of the apixaban?
not prophylactic.
Oh, right. He's on,
Therapeutic.
he's on
There is no
therapeutic.
prophylactic dose of apixaban.
He's on therapeutic anticoagulation long term because he had an unprovoked massive.
Massive.
Yeah.
How high is the risk in that situation?
Right. I think it's a risk versus
Not-
benefit because as
not
Dr. Lovano said,
quantifiable.
ongoing risk of inflammation is a huge risk factor for him as well. Dr. Mahandru?
So I have a question for the panel actually. At what point, it comes back to, I'm still not able to understand, you know, and we see these people all the time. So at what point do we start thinking about doing a genetic test to see if he has something that is predisposing him, or is it failure of treatment? And I'm not sure I agree, Louis, when you say that calpro, to me calpro is a great biomarker for UC.
well, it is, but I think that it's a binary biomarker. You know, using calpro as a dynamic biomarker is different. So what's the difference between a calpro of 1,500 and 1,000? Is that a response?
But anyway, he's
So that was my point more.
Okay.
Not,
CRP
yeah.
is the best marker in that case.
But I think that, you know, again, if I had gone back in time for him, he's somebody that I might have, I would agree with Bruce, I would have given him 10. If he didn't have an immediate response just because of the amount of morbidity, I mean, he's now has no kidneys. So a kidney transplant kind of stinks. And, you know, if he didn't respond to that 10, and I agree with you, Lincoln, right? And it's not a great surgical case. I'd give him the JAK with the shared decision making. And again, within a week, if he's still not responding, going on and on for months and months with him, then Sergey's just going to have to do his best.
Just
It's not that
additional,
we're not only running out of time, we're running out of options here, right?
Right.
So the reason I kept him on the anticoagulant is precisely because I've never been able to bring down the inflammation. So everything's just not going the right way. He's
Yeah.
still very young, and that's what we're here. But he's on 10. I started him on 10 today. Obviously, the calpro, it doesn't really mean, but it's going down. It doesn't really mean much, but it's going down. But I think I'm failing because the CRP has never been this high.
How high is it now?
It went from, let me get it here, I got it at, it's 60, and he was always, he was always
20s.
like around the 20s or something. But
Game
it's
over.
60
One-
now. I'm going to start he was just loaded. I'm going to start at 10 on his second dose, but I don't know. I think
Use a
that
JAK
I
on.
want to give this guy a JAK and just have a shared decision with him. But that was a really bad PD that he had.
Yeah.
You
I mean,
don't want that. I'm sorry. Is the ASR, not CRP. The ASR is up to 60. He doesn't form CRPs. This guy, the CRP has never worked for him. The ASR is the one that I'm relying on.
Okay. So
just
we're going to have, we're gonna do two more points, and then we're gonna go to the next case.
By the way, just 2 infusions and then go to the JAK. I wouldn't waste much time. I agree with Louis. Sergey, what about, you mentioned that doing a subtotal colectomy is still going to pose a lot of problems for this guy.
oh yeah.
What about a total proctocolectomy and a permanent ileostomy?
Definitely would
maybe
not
just
do it. Okay, so I would definitely, absolutely not do it as a first, like just go do it all option. That is a bad idea. That in this patient with BMI of 39 or 42 now, it equals 6 hours of surgery probably in lithotomy position, which equals probably another PE, God knows what. The other pound of salt in this whole story, patients with ileostomies and CKD.
I'll come down myself.
Dr. Sacker, could you mute?
Patients with
I missed a few minutes of the discussion, but they bring up the idea of combining the infliximab with anti-interleukin 23.
Yes,
since there's such good data on that.
We talked about potentially adding vedolizumab since he had a partial response
Not
to that.
vedolizumab, no.
No, I know you're asking about an IL-23.
Anyway, you do the
hold on.
stoma in patients with borderline kidney function pre-dialysis, you put them into dialysis.
Okay, so the point that Dr. Kaitan
I'm
made is
talking
that
about
if you give him
ileostomy.
an ileostomy, he'll go
fluid
into
disbalances,
renal
a couple
failure because
episodes
of
of
fluid.
dehydration, and you're done.
So from a
So-
surgical standpoint in the obese patients, so let's say independent of the
Last
kidney
thing,
failure.
sorry, Lewis, and then we have to go to the next one. Sorry, keep going.
So you mentioned a couple concerns. So one is doing the proctectomy is technically challenging.
Yes, we can do it later. It's not going to make
Once he's
him
lost
sick.
some weight.
That's a great point, and that's what I wanted to add. The options of weight loss don't end with GLP. There is sleeve gastrectomy.
Right.
And then there
Which is
ostomy-
low risk surgery, which can be done if he stabilizes somehow before or after colectomy. We've done this after, and that converted some patients to manageable surgical, patients
Right.
with next step options. It kind of converts him from BMI 42 to 30. That's a huge accomplishment.
And then you could even consider
I
maybe,
would-
or no, you
that
wouldn't.
I would not go that
Okay.
far there because it may become a problem. But
Right.
again, subtotal colectomy is doable for sure. It will be a high-risk situation. No total procto as a first go. And then at some point, non-medical weight loss, surgical weight loss reduction.
Can you just clarify for everyone why because I think Lewis was saying, would you consider a pouch? And you were like, no way. Why is a pouch not an option?
J-pouch.
J pouch.
It's just a bad option because typically these patients, even they lose weight, it's kind of still remains very challenging to do proper cuff length. With active proctitis, the patient we kind of convert one suffering to another. Bad pouch is much worse. I love to do them than good endoleostomy.
Right.
That's my strong belief.
All right. On that note, amazing discussion. I'm so sorry we have to cut it off. I'm going to go to the next case because it's also a very interesting one. Thank you, everybody, so much.